Thank you. It's a great pleasure to be here, and I have to especially thank the projectionist whom I completely challenged in this last few minutes. And if these slides look peculiar, just blame Bill Gates. Being a completely anti-PowerPoint person, I showed up with a keynote presentation only to discover that program isn't here. And so we made a very last-second conversion, and I can't wait to see how they look. As a point of departure, I wanted to maybe remind you of this picture. You probably have seen it before, and it comes up as, I think, a good metaphor for what I believe is going on in the world of so-called personalized medicine, which is a buzzword that undoubtedly you've heard many times. And I like to use this picture because many people bristle at the notion of personalized medicine for a few reasons. The first is that it implies the existence of impersonalized medicine, which actually I think exists on a pretty wide scale, but few would claim to practice that. And also, many would argue, well, we've always been practicing personalized medicine. In fact, it's kind of a redundant term because medicine is by its nature personalized. And I use this picture to make the point that, sure enough, personalized medicine, in some sense of the word, is a very old concept. And you would agree, I'm sure, that the physician who is depicted in this painting, who's taking care of this gravely ill child, is practicing personalized medicine in every real sense of the term. But another thing you can see in the background over here are her distraught parents, and I think you can probably tell it on the face of the physician as well. And that is that he absolutely has no idea what to do to help her. And I think that, in my mind, is the big transition that has taken place and why people are so interested in this concept of personalized medicine, or I'll focus more today on genomic medicine. It's not so much the ability to take care of an individual patient and put their needs as the foremost thing in your mind. It's the fact that we have a lot more at our disposal than we ever did before to actually affect a better outcome. So you've heard a lot at this meeting already about genomics in medicine. I think most of the talks have focused on genomics as it would apply to fairly familiar instances of relatively rare disorders, trying to make diagnoses in circumstances where conventional testing has made that diagnosis elusive, or applying cytogenomics to particular diagnoses. And I'll say a few words about that as well. But the question that comes up a lot, and increasingly will, is not so much the application of genomics to the rare conditions that we as geneticists have historically tended to focus on, but what about the genetics and genomics as it applies to day-to-day medical practice? And I show this picture to indicate what many would conceptualize as the kind of skeptical attitude of physicians, and the question could be asked, so what exactly is going to have to happen in order to integrate genomics into the workflow of the clinician on a day-to-day basis? And I'll try to focus on three areas very broadly: the concept of clinical utility, because if you can't prove that the outcomes are improved by virtue of genomic applications, then you're going to have a lot of very reluctant physicians standing on the sidelines. Second are some of the ethical issues, which have been alluded to by others in the meeting in this last day or so. And then thirdly are some educational issues that I believe will be needed to be addressed in order to see genomics make it into the mainstream of medicine. And I'll frame this in three contexts: that of prevention, diagnosis, and treatment, all of which I think will be familiar to most everybody here. Prevention is not a new concept, and it's been well discussed in the last few days here and is familiar to all of you. Without question, I think this is the major public health contribution of genetics over the last several decades, and certainly needs no introduction here. We've witnessed just what it takes to take a test from a relatively low throughput and focusing on just a few disorders to a much wider application through tandem mass spectroscopy over this spectrometry over this last several years. So I think it's a familiar concept that prevention can make a huge difference. We've heard in the last talk even about other prevention opportunities. And it's not a new thing also that we are faced with the need to educate a workforce that is largely naive to many of the conditions we're dealing with. The typical scenario in newborn screening is the kind of Friday afternoon. I guess this is just about the time when some of these results should be coming off and coming to the attention of primary care pediatricians who will be hearing about a condition that generously they maybe once heard of and forgot. There's a pretty good chance they never heard of. And now they're suddenly faced with the need to deal with this right now in real time. And they may not be able to reach a specialist over the course of the next 2 or 3 hours. I point out these ACT sheets that the American College of Medical Genetics and Genomics has put together, which were intended partly as an approach to providing point-of-care information in a circumstance where newborn screening would result in an unexpected finding, but also as a proof of principle of a broader concept, which is how do you put information that's just the exact thing you need to get through the next couple of hours into the hands of a primary care physician, just to tide them over until they can make contact with a specialist. And this was actually, and still is really, a kind of a paper or web-based approach, but over the course of time, and I'll say more about this later, the integration of these kind of point-of-care decision support tools into electronic health records and prescribing systems, I think, becomes increasingly an opportunity. Question has been raised now, as you're aware, I'm sure, of whether a genomic sequencing approach would be a better way to offer newborn screening than the metabolite-based approach that has carried us for this last half century or so. And as you're aware, the NHGRI is now beginning to fund some pilot projects to actually look at what the clinical utility would be if newborn screening were accomplished by a DNA sequencing approach. I pull this screenshot from a paper that actually was not on the subject of newborn screening. You're probably familiar with the paper where they looked at, I think, 400 some odd tests, really with an eye towards carrier testing. But the same issues apply, and I pull this one quote from the paper, which I think is an important thing for us all to keep in the back of our mind, which is they found lots of examples of purported mutations that were thought to be pathogenic that in fact were not well annotated as pathogenic. But the literature, I'm afraid, is littered with examples of so-called mutations that have been published and attributed to particular phenotypes, and it'll turn out in some of those cases that these were single case reports many times in the distant past and never further verified, and oftentimes not at this point clearly associated with the phenotypes that they've been attributed to. There are cases, I know, that particular mutations have been found, even decisions made on them, and then you look back in the literature and you realize it was one case report in 1986, and you contact the author and discover that they had long ago decided this was a benign variant and never bothered to publish a correction on the original paper. So I think we need to be very, cautious and be aware of the misannotation of mutations in the literature and the need to be very critical in looking at these from the perspective of predicting phenotypes. It's one thing when you have a phenotypically affected individual in front of you, and perhaps the ability to do further analysis to actually verify that the mutation is real. It's quite another thing if you're doing this in a newborn screening context or even a prenatal context where there is no phenotype at the moment of testing, and you need to predict what the phenotype would be, and if the literature annotation is wrong, then the prediction will be wrong as well. Carrier testing would be another application of the same thing. This is a familiar, I think most of you, list of some of the carrier tests done based on ethnicity. And the other point, which I pull from this same paper, has to do with, well, just how often is a person going to be positive if a carrier test is done based on sequencing, and this was just for several hundred particular mutations, not for 20,000 genes. In this paper, a small number of people were not carriers for anything, but almost everybody was a carrier for something, and in most cases people were carriers for multiple things, which raises the question of who's going to do the counseling for those individuals on the presumption that they're going to want to understand what carrier status means to them. Most probably, in most cases, the two partners will not be carriers for the same thing, but of course sometimes they will be. But likely they'll want to at least understand what the significance of this result is. And when we're talking about not the occasional screen positive patient, but 100% of your patients, which is what will be the case as you look at more and more components of the genome, the need for counseling resources becomes greater and greater, a point I think that Kathy made yesterday, and which I certainly agree with. We heard just a few minutes ago about non-invasive prenatal screening. I won't say very much more about that except to point out that it's a good example of, well, a couple of things. One is just how quickly things can move from a proof of principle into mainstream testing. I mean, I suppose quickly is a kind of ambiguous term because this was years, maybe even decades in the making, in the background. But from the point where validation took place to the point where implementation took place has been a very short period of time. And the second interesting issue is how this is being driven much more by industry than by testing within academic labs in this case. So unlike many examples of genomic testing where individual academic labs have built it into their workflow, as I see it at least, this seems to be gravitating towards a handful of outside reference labs. It'll be interesting to see the extent to which that kind of trend continues over the course of time. What about direct-to-consumer testing from a kind of prevention or even potentially diagnostic paradigm? This has been a obviously controversial area over the last few years. You might argue that the marketplace is somewhat exerting its hand here because, as far as I'm aware, there's mainly one player left in this. There were several at the beginning. The question can be asked, if this survives, what kind of future does it hold? I'm showing you the screenshot of my result. I did do the testing, and by the way, have no conflicts to report. I paid for it myself, had it done. I figured after teaching about it for a long time, it would be a worthwhile thing to actually have the first-hand experience. I venture to guess I'm not the only one in this room who's played around with this. So what I learned from this particular screenshot shows my odds ratio of type 2 diabetes. Notice that it's, if you can read it from where you're sitting, essentially it's at the population risk, if you believe the result, which I guess I know well enough not to bank too much on it. That's kind of what I found, by the way, for the many, I guess even dozen common disorders that they tested for. I found out that I was at average risk for everything you've ever heard of, and come to decide that's okay. I could have been worse, I guess. I also know that this needs to be taken with a pretty significant grain of salt. Knowing that my risk of type 2 diabetes is about average has not changed my behavior. I guess if it had been shown to be much higher than average, it's an interesting question as to whether I would have actually had more motivation than I really do to mind my diet and exercise. I do think I know enough that if my risk had been shown to be much lower than average, that I wouldn't have just decided that have all the dessert that I want. I suspect that I had more baseline knowledge of this than a lot of the people who have been tested. But nonetheless, the clinical utility of this is pretty minimal, I thought, and I've mostly come to the conclusion that this was what many people have described as recreational genomics or cocktail party genomics. To me, that means that it's worth about maybe 3 or 4 minutes of cocktail party conversation before whoever you're talking to gets bored, and wise not to carry it too far. I would raise the question of whether this should be conceptualized as a so-called disruptive technology. I don't know if many of you have gone into the literature of disruptive technology. It's really fascinating, mostly business literature, and the basic idea behind it is many technologies that we now take for granted and which are part of our day-to-day life had their origin in approaches that were really not very powerful. And a fairly obvious example of that is a personal computer, which at the time when it was first invented, which would be in the 1970s or early 1980s, what constituted a computer that most businesses ran off of filled the better part of a room. And some of the companies that were building those kinds of computers and making a lot of money off of them saw the personal computer come along and inquired of their customers, is this of interest to you? And everybody kind of laughed at them because you couldn't run a business on the kind of things that were being put forward at that time. You could play games pretty effectively, and so it wasn't nearly powerful enough to do the things that they needed to be done. So at that time, the personal computer was way down here on performance. Put differently, it was effectively a toy, and the mainframe computers were up here. But as you well know, over the course of time, the computers got better and better to the point now that many of the companies that were building these room-sized things are out of business, bought by, in fact, some of the personal computer companies, because the quality of the technology got better and better. So I use this metaphor in the context of genetics. We're familiar with the paradigm of a single physician or counselor or some combination thereof in a room with a patient, one at a time, mostly one gene at a time, talking about a particular condition that might be relevant to their situation. And you could imagine as we do more and more of this, we get better and better at it, so the efficacy maybe goes up or the performance goes up over time, but at a fairly slow pace because it's a fairly mature technology or approach, if you will. The consumer-driven testing is this recreational toy right now. The question is, will it gradually climb this curve over the next several years to the point where it becomes more of a mainstream approach? Because the one thing they have done pretty well, I think at least, is develop very, very good quality conduits of information to individuals. And as the volume of data needs to increase, the ability to use the kinds of approaches that some of these companies have developed becomes more and more important. So I think maybe the message here is that we ignore this at our peril because this paradigm, whether it's one that you would embrace now or not, is going to be, I think, one of the contenders as we are faced with more and more volume of data that we have to communicate. From a diagnostic perspective, you've heard already many times at this meeting, and I won't belabor it, how genomics has already invaded the clinic, if you will, and this point comes up where a lot of people ask, all the money spent on the Genome Project, has it made any difference in clinical medicine? And the answer is yes, obviously it has. Not always so easy to convince the people paying for healthcare that it's made a difference, and I think you're aware of some of the controversies, and it's actually getting worse before it gets better in terms of the CPT codes for both cytogenomics and even for molecular genetics. Right now it's a real battleground which ACMG has been heavily involved in. But from a clinical utility perspective, I don't think there's much doubt that genomics has made a big difference, and many of the talks at this meeting have already pointed that out, and as well the now utility of exome or even genome sequencing in short-circuiting the so-called diagnostic odyssey that so many of us have participated in over the course of time. And these are two screenshots from papers that most of you are familiar with that illustrate the application of the exome sequencing approach achieving diagnoses. And you've heard many examples of that in this last day, I know. A point that doesn't get mentioned much, though, and which I think actually deserves a few moments of thought, is that if you're doing exomes or genomes, for that matter, on any kind of wide scale, and I'm now talking not at the level of trying to diagnose an unknown disorder, but if it were ever to be the case that sequencing were to be done on a wider scale as is part of routine care, you will indeed, of course, diagnose various conditions that you may or may not have had clinical suspicion about. But I think one of the kind of hidden utilities of this over time may be in the realm of differential diagnosis. And what I mean by that is that if the sequence were to be available for re-query at some point in time, and I'll say more about that in a few minutes, you can imagine that somebody who doesn't have an unexpected condition like Marfan syndrome that gets diagnosed where they might not have had reason to suspect it clinically, and who doesn't learn much that's going to change anything about their carrier status, for example, someday comes into a physician's office with a swollen joint, for example, and there could be lots of reasons why that's happened, ranging from rheumatoid arthritis to osteoarthritis to many other autoimmune disorders. And will the genome be queried because the sequence is there, not so much to predict that this person is going to someday develop some form of arthritis, but to help you sort out the differential diagnosis because he already has developed arthritis. And of all the many kinds it could be, it may nudge you in one direction or the other to have more or less confidence in one particular diagnosis. And I think that differential diagnostic sort of nudging effect may in the long run be more powerful than the predictive, because I guess I tend to be a bit of an agnostic in terms of the predictive value of genomics to ever tell us who's going to develop common disease, because as you know, the heritability that's accounted for by most of the single nucleotide polymorphisms identified to date is only a relatively small proportion of the attributed heritability, which either means that heritability was overestimated or the particular constellation of genetic findings that characterize risk for a given individual are so unique. It's kind of the irony of personalized medicine. It's so personalized that it's only you who has that constellation, and you're not going to have enough data to predict with any real precision exactly who's going to get what. But once they've got it, if you want to have some ability to sort out how they got it and what better way to treat it might be, I think you may find the genomic sequence will come back as a significant aid to diagnosis. From the therapeutic perspective, there's been a lot of discussion at this meeting and, of course, over a long period of time about some of the biochemical therapeutics, which have obviously been a source of enormous benefit to the patients that all of us deal with. There's been progress at other levels. I use this diagram of the cystic fibrosis physiology to point out the mutations that either lead to degradation of the protein or abnormal function at the membrane that now either so-called potentiators or correctors have begun to be developed, which now means that genotyping an individual with cystic fibrosis is important not only to offer genetic counseling to the family, but also increasingly, I think, to identify particular therapeutics. Ivacaftor, which is the kind of first example of this, but I suspect not the last, is a treatment that is specific to a particular kind of mutation. So it matters to know what a given individual's mutation is. And even though it only affects or it only helps a small proportion of people with CF, if you're one of those people, it can make a big difference. And the idea of using the knowledge of a particular mutation to develop therapeutics that either affect the protein, which is what it does in this case, or even can, for example, overcome stop mutations or affect abnormal splicing, all of which now is feasible to do, raises a whole new sort of class of possibilities for treatment based on accurate genotyping. There's been a lot of other areas of interest from the therapeutic perspective. A lot of these have happened in the context of cancer. It's probably been the early adopter of genomic technology because, as you know, cancer is fundamentally a genetic disease. Imatinib, the drug that's used as an example of tailoring a particular small molecule to a specific mechanism, in this case the BCR-ABL translocation, is well known, I think, to most. At the lower left, the ability to predict responsiveness to Herceptin in breast cancer, the RAF mutation that BRAF mutation that occurs in some melanomas and predicts responsiveness to drugs. The diagram at the center showing the amount of information that genomic sequencing of a malignant tumor can provide in terms of genetic rearrangements and assistance in selecting the appropriate use of medications. And then the more familiar, probably, approach of looking at pharmacogenetics, in this case, of warfarin metabolism as an example of tailoring therapeutics to a particular individual's patterns of drug metabolism. So this actually is the listing of some of the pharmacogenetic polymorphisms back to my results from the direct-to-consumer testing that I alluded to earlier. I know that you can't read it from where you're sitting, but I'll tell you the first thing on this list is that I have increased sensitivity to warfarin. So what that means is that if I were given a standard dose of warfarin, I would be at risk of hemorrhage as a consequence. Warfarin, the blood thinner, if you give too much, hemorrhage is the outcome. If you give too little, the deep vein thrombosis that you're trying to avoid may in fact occur. But you would think this would be rather useful information to know, and it is, I think, except for the obvious problem that if ever someday I were to need to be treated with warfarin, the only thing you can be pretty sure of is I'm not the one that's going to be prescribing it. Yet I'm the one who knows it, and the chances are nobody in this room will be prescribing it either. But the fundamental problem is whoever is going to prescribe it is probably not going to know this, and there are a few reasons why. I actually printed this out and handed it to my primary care physician a while ago, just after it was done. And I got the predicted response, which was like, what on earth am I supposed to do with this? And I know what he did with it. He put it in a pile on his desk, and if I'm lucky, it got put into the paper record, which is fine, except like most places, we no longer use a paper record. And it might have been scanned. That would be a very optimistic and unlikely outcome, but it might have been scanned. But if it did, it's just buried in a kind of list of other scanned documents, and it won't be labeled as, this person's pharmacogenetic results. And even if under, if all the stars aligned and, that day in the emergency room somebody actually did see it, they'd actually have to know what to do with it and how to modify the dose. And I think it's a very fair guess that they don't. So the point here is that the clinical utility of this, or at least the clinical validity of this is well known. Clinical utility is perhaps debatable if you're saying, is it cost effective to do this testing on everybody? But it's been done here, right? It doesn't cost anything more to do warfarin testing. And so that cost is off the table. And so the clinical utility is probably not really debated even, but the systems are not there, is the point. There are no information systems, at least in our institution, that automatically integrate this. And that's a point I'll return to in just a few minutes. Well, from a kind of perspective of applications of genomic sequencing, in the extreme, one could even imagine doing prenatal diagnosis. And as proof of principle, as you're probably aware, there are examples now of where an entire fetal genome has been sequenced based on the fetal DNA that finds its way into the maternal circulation, raising the question of what would be the utility, A, in diagnosis of a condition that fetus might be at risk for, but B, in terms of screening for anything that's possible. And I know this was discussed over the course of the last day or so, but what to do with incidental findings. This is a screenshot from Zach Kahani's paper where he coined the term the incidentalome. And his point was that if you do a sufficient number of tests, and when you sequence a genome, you are doing a sufficient number of tests, there is a very high probability of finding something incidental defined as medically significant but not the original target of what caused you to do the sequencing. So you've heard in the last day, I know, about the ACMG list of incidental findings. It's generated, as you're probably aware, a fair amount of controversy in the larger community. It consists of 56 genes where the committee or the working group that was asked to look at this felt that it was fundamentally irresponsible for a clinician not to be paying attention to these, because identifying one of the known pathogenic mutations in these genes, and the definition of that was very tight, I might say, in an individual who might not have previously known that they were at risk, would benefit from learning of this mutation because there would be an approach to risk reduction, to actual initiation of treatment. And it's generated controversy because the recommendations were that the laboratory deliberately seek these and report them to the referring clinician. It leaves it a bit ambiguous how the referring clinician will deal with these. It doesn't force the clinician to tell the patient these things. It's true that these may well wind up in the medical record, and I would venture to guess most clinicians would feel an obligation to report them. The truth is, of course, it's the clinician, not the laboratory, who is in the position to contextualize these results into the known issues that that particular patient may be dealing with. You know, somebody who is dying of a particular disorder and has no first-degree relatives might be treated very differently from somebody who has this test done to make a diagnosis of an unknown disorder with a large extended family and suddenly is discovered to have a BRCA1 mutation that's a known pathogenic mutation. I use this metaphor of, you know, would you, if you saw somebody walking down the street with a flower pot about to fall on their head, or the other metaphor is crossing the street and doesn't notice a bus coming about to hit them, would you sit and say, well, I don't know if this person really wants to know this or not? You know, these were not conditions that maybe someday you might get them and maybe something possibly could be done about them. There were all things with exceedingly high penetrance and with well-defined pathways to intervention. And remarkably, a lot of things did not make it on the list, including the disorder that I'm most interested in, NF1. And the reason why was, the feeling was that if you have NF1, you should be able to figure that out clinically. It shouldn't require a genomic test to do it. NF2 did make it on the list because lots of people will go decades not realizing that they're affected with vestibular tumors until they've grown so large that they cause a symptom. So it gives you a kind of a window on the thinking. Right now, by the way, ACMG is in the process of trying to come up with a mechanism to maintain this list and continually update it. Certainly was aware that this is not the final word. It was meant to be kind of a place to start with this process. What about the educational issues? And let me tell you a story of a case that actually happened in our clinic just to illustrate this, as I guess we'll need to wrap up in a minute. So this was a family with multiple endocrine neoplasia. Remind you the symptoms up here, parathyroid and pituitary tumors and so forth. This young child actually was seen by an endocrinologist because of chronic diarrhea. And they knew this family history, so they figured, well, they'll get a genetic test to see if the child actually has this, maybe wondering if there could be a relationship to the diarrhea. They get a result back from a commercial lab that says variant of unknown significance. This is not copied from the report, it's kind of based on it, but it's a pretty accurate depiction of the diagram they showed. And somehow they knew that this was right smack in the middle between being pathogenic and benign. Never sure exactly how they knew that. Well, let me tell you that this child got labeled in the record as having multiple endocrine neoplasia, and they began to plug him into a follow-up plan. It is true that children do get followed for MEN, not usually at 18 months of age. But anyway, that's what they did. Well, a little bit of time passed, and the mother came to the attention of an adult endocrinologist who actually was wondering if the family diagnosis was correct. Referred the mother to the genetics clinic. So she had a test that was sent to an academic lab, and they found a known pathogenic mutation in her that had been annotated well and was different from this variant of unknown significance in her child. We queried the lab that did this original test, and they refused to report whether this was seen or not, but they told us that the test would have seen it if it had been there. I don't know how much confidence to place in that, but I think it's a fair statement at this point that this child must have inherited this variant from the unaffected father, clearly didn't inherit the pathological mutation from the mother, and doesn't have this, but I can tell you that it's going to be a long time before this is expunged from his record as what he has. And I guess I make the point because you could say this endocrinologist who saw this child knew enough to realize there was a risk to this child. And by the way, it turned out to be a viral gastroenteritis for the diarrhea. Knew enough to think about genetics, knew enough to arrange genetic testing, but got thrown off when it came to this interpretation of a variant of unknown significance, and I think in some ways did some harm in the process. So in order for this all to hit the kind of day-to-day practice of medicine, there's going to need to be a kind of new approach to education. I don't argue that all clinicians need to be completely sophisticated about the interpretation of genomic testing. On the other hand, they need to know at least enough to help support the counseling to families, and frankly also to know their limitations. And there are lots of interesting new paradigms, the so-called MOOCs, the massive open online courses, things like the Khan Academy as ways of doing this. This is an iBook we created at our place to support a course on genetics and genomics and clinical research, and other kinds of things. We've opened an iTunes channel to begin to educate some of our own clinicians. I think we need to think carefully about new training paradigms in genetics. The ones we're most familiar with are starting in things like medicine or pediatrics and then going into medical genetics. I'm talking obviously from the physician perspective, or the combined programs. But there's increasing interest in taking individuals who have very focused interests, oncology, cardiology, neurology, and are not going to do a 2-year genetic residency, but want to do genetics as it relates to their specialty. And as you well know, they're doing it with or without formal training. Wouldn't it be better if we could provide them a year, say, of fellowship training that didn't lead them to be a board-certified medical geneticist, but at least to have a certificate of competency in the genetics as it relates narrowly to their field? Honestly, they are going to do it with or without us. Wouldn't it be better if they did it with us? So let me end with a point about the kind of workflow that I think is likely to occur, and then I'll say a word about what's going on at UAB and wrap up. If we're going to see genome sequencing in the clinic, when would you do it? Prenatally, in the newborn screening period, or in childhood? These are all attractive because they give you the opportunity to intervene very quickly, but they're problematic because you learn about a lot of things you probably aren't that anxious to know about, certainly an unborn fetus and even a child, in terms of adult onset disorders. Adulthood, you can provide very good counseling, but you've also foreclosed the possibility of actually applying this in a kind of preventive way. Where would the information live? In the electronic health record? Good luck getting your EHR people to put all the genomic information, but certainly it's a possibility. But if they did, how helpful is that going to be when you move to another place? Because we don't even get accurate medical records most of the time from one place to another. Would you imagine transmission of genomic information in that way? Would it live in the cloud? It might, if you are comfortable with the security, but that would be a possibility. Maybe carry it on your personal devices, whatever those might be. Or this one is the most efficient place to store genetic information is in the cell nucleus, and no one ever forgets to bring their cell nuclei to the doctor. I think it may well turn out that we'll reach a point where it'll be cheaper to resequence than it will be to try to store the information. So maybe that's the long-term answer. You won't see this other than to know it's a screenshot of iTunes, and I make the point, think back 10 years now to the days before this when it was real jungle in terms of downloading music, and it encouraged all sorts of law-abiding citizens to break the law because there was no ready alternative, actually. And it wasn't until iTunes came along that somebody organized this and provided a kind of a legal outlet. And I think many of the same things will apply here. Our electronic health records, I think, are not designed to improve healthcare. They're designed to improve billing and compliance. And you know, the day that somebody comes up with the iTunes equivalent for the electronic health record, that's the day you're going to see genomics be used in day-to-day medical practice. So we've put a fair amount of effort into trying to build a program at UAB. I won't really go into any detail except to say that our hospital administration came to us, which is a new thing, saying that, you know, they've been noticing all these interesting things. What can we do here? We've developed a genome sequencing approach, as I know many of you have, and Nita Limdi at our institution has developed a pharmacogenetics program that does integrate warfarin and clopidogrel testing into the electronic health record, and over time additional things. And it's attached to both research and clinical care, and both patient and provider education. Just in a month, we're doing a CME course for our community to try to raise the consciousness of practicing physicians in this area. So I'll conclude at this point. I think I'm pretty much out of time. If there's time for questions, be happy to answer them, but I'll maybe end with the fact that, you know, the days when geneticists occupied an obscure corner of medicine, honestly, I think are beyond us. And now the question isn't so much, you know, how do you get support to do the things we've always tried to do, but how do we rise to the opportunities that I think are huge to take what we know and begin to apply it into the kind of mainstream of medicine. Thank you.